Hello, hello everyone. Can you hear me? Hello, hello, hello. Can you hear me?
Hello.
Hello.
Yes, we can hear you.
Yes. A very good morning to all the speakers and delegates present over here. I am the moderator of this virtual session of the Scholars Conferences. It gives a pleasure according to invite the hybrid event Scholars World Congress on Nursing World and Advanced Healthcare. I thank you all finding time in your busy schedule to hear it. Today we must major activity in the brief experience of the Scholars Conference. A moment here we are interacting, sharing experiences, reflections on various areas. This virtual session is a remarkable event which brings together professional researchers and students, making the virtual session is the perfect platform to share experience, foster collaboration across industry to academic, and evaluate the technologies across the globe. Now we will start the speaker session. Now I call upon Admin Wilson University, Turkey, to deliver her talk on mobile care app development process using ADMI model of management system of the breast cancer surgery. Step 1. Doctor, please proceed.
Thank you so much.
Thank you.
Hello, everyone. I can share my presentation. Just 1 minute. Okay, that's available for you. Can you see
Yes,
it?
doctor.
Okay.
Yes, doctor.
Okay, thank you so much. Have a good day. Good morning for you. Good evening for me in here at 11 o'clock. And then first of all, I would like to thank the organization group for their invitation. It brought together experienced researchers from different countries on this platform. I also hope the weather is nice in Paris, and those who listen to us have a pleasant energy right now. I would like to introduce myself. I was invited to Congress from Turkey. Gümüşhane is a small province in Eastern Turkey. I'm here at university as an assistant professor doctor. Today, I will tell you about my process or my doctoral thesis that I completed 3 years ago. And I hope my speech will inspire you while listening. And that's okay. I started with an idea. The idea was to create a cure for cancer patients. I wanted to test this, especially in breast cancer patients. I chose this cancer because it is very common among women and has a good chance for survival. Cancer is a serious health issue affecting millions of people worldwide. Cancer treatment can be a challenging process for patients involving physical, emotional, and psychological difficulties. Effective symptom management plays a critical role in improving the quality of life for cancer patients, ensuring treatment adherence and enhancing overall health outcome. In recent years, a mobile app usable for cancer patients or management of symptom. Mobile applications have emerged a potential solution for symptom management in cancer patients. This academic study, a lot of academic study, including in mobile app, introduce symptom management or etc. My academic study or my doctoral thesis, mobile apps in treatment and management of cancer patient symptoms. And the role of mobile app symptom management include in this studies symptom management, advantages offered by mobile app, accessibility or readability, personalized care, symptom monitoring and tracking, maybe providing information and resources, pain management application, fatigue and energy level application, nausea and vomiting management application, sleep problems, coping application, depression and anxiety management application, etc., different symptoms. Enhancing patient skills in monitoring and tracking symptoms. Increasing treatment adherence and self-care. Self-care is most important for cancer patients. Increasing self-care for available mobile app. Encouraging information and experiences sharing among patients, improving communication, so important for cancer patients and healthcare providers. We had a lot of problems until the research reached the first users because we couldn't get acceptance from an organization that would finance us. Until we got this acceptance, we had 32 project applications, and that got us a year of administrators. I reached the first users, just 1 minute. We want to determine the impact of nurse-led support via a smartphone app or mobile app among breast cancer patients after surgery. Was aimed to this quasi-experimental study. We can try this quasi-experimental study. October 2017, in opinion, start with. June 2018 is mobile app available for this store. January 2019 is available for first users and is very pleasant for us. I started statistical analysis and now share with you this end of the presentation. June 2019 is status analysis, and I will share you these conclusions. We can look at this previous research. The mobile app had many good and bad impacts. We have learned different ways thanks to this research. I will share you details with you soon. Breast cancer had many different problems. In order for the mobile app to be successful, it had no offer solution to all problems. It was a difficult process to offer solutions and to all the problems to be experienced. And to do this with a mobile app for available. We tried to manage this process 34 different problems. So pain, infection, exercise, psychological problems, bleeding and drain, follow-up problems, back to business life, or etc. survival problems. Had a lot of problems experienced by the patients. I investigated defined training models, structures, mobile app contents. First step, we can use the AD models. First steps in AD analysis. Second step, design. Third step, development. Fourth step, implementation. And the last steps in evaluation. The first steps is analysis. The analysis is the first step at the model. Design educational materials at the stage is necessary. Overall pictures, including in the app. This is completive stage is necessary. Think about the patient-centered approach for the design of materials. Design is available analysis files in conjunction with the theories and model instructional design is made to explain how to learn will be accurate. This is important for this stage. How we learn will be accurate. At this stage, information contact that application will provide the patients how this information will be transferred. Text or video or picture, 3D animation or etc. How this information will be transferred. And the second, the other step, development including in software process, in software engineering or company, but together us. And the APK Uzant is including in the Google Play or Google Play Store or iOS Store is available for the mobile app, including in the download on the store. The other step, implementation files represents including in the mobile app process. The end of the implementation, final files including in your app. The last step, evaluation. Evaluation is the process including in the phone or inside in the phone and by the researcher. Presentation brochure give the patients after the provide its evaluation. Development in the app. The end of this stage after the available for mobile app. This is my process, including in the app, including in the 3D animation. Just 1 minute. This is not available for now, but 3D animation included in our app. We agreed with the theater actor included in the app, make this process close to reality. We attached this sensor including in the Brooklyn, and with this move after the 3D documentation including in the digital platform, move the transfer the digital platform. We collaborated with the software developer and create animation character, including in the character as a different character may be usable for this application. Just is 1, 2, 3, and 10 face, including in the Google Forms prepared for the application, and ask patients who had previously been treated at the same hospital, then high point including in the face, including in this. This is available for our patients, our mobile app animation face. We decided that the patients with the most votes should be application phase, and this phase was chosen. Here, see the application contact, but not code available for now. User login here, just one. User login here, and this section users can ask question is available now in here. When the section click on this, click on the button, a list of problems open, and they can may choose. There is a video and contact for each issue, each part of this symptoms. they can whichever they prefer after then usable 3D animation, can video or text. Mobile apps are emerging as effective tools in the management of cancer symptom management. These applications not only assist patients in monitoring, tracking, and managing their symptoms, but also provide advantages such as personalized care, information provision, and resource sharing. Mobile apps have significant potential in improving the quality of life for cancer patients, ensuring treatment adherence and enhancing overall health outcomes. However, further research and clinical studies are needed to evaluate the effectiveness and reliability of mobile apps. Advancing in this file indicate that mobile application can continue to be widely and effectively used in cancer patients. We can find it mean scores, shoulder function, sexual adjustment, body image scores. The intervention group were higher than use of the cancer patients in the control group. No differences between first and last measurements mean score all dependent variables in control patients. And it does mean statistically the significant differences between intervention group. That is so important for us. The smartphone app, no question were asked that could require nursing care. These results show us the app was successful in symptom management and no additional requirements were needed. The mobile app was found produce effective results in symptom management. Patients who asked question with seroma is more important for breast cancer symptoms. Seroma felt a mass in armpit. Patients who asked question drain, concern about the immune bleeding. This contribute to the stress she was experiences their self-care role. So important self-care role, including in the mobile app for available. That is important. That is so big deal. Positive effect for process the cancer patients. Smartphone app have been customized for different area are used and for management of different type of diseases. The prevalence of use, the number of users in filed health is steadily increasing. In addition, being an option in management diseases, follow-up symptom apps can act as an indispensable bridge in patient-physician integration. They are widely used in providing information related to the early diagnosis of breast cancer and achievement behavioral change. Our study, which set out to determine how smartphone use could contribute to the management of symptoms or problems experienced by individuals undergoing surgery, showed that kind of apps can be effective in relieving pain as well as symptom-related morbidity, anxiety, sexuality, and body image. This is so important conclusion for us. The success of symptom and in managing each symptoms separately make us believe that is possible to manage the process after surgery with a single tool. Thank you for your attention. That is a conclusion for me. Thank you so much for listening.
Thank you for your Thank you for your speech. If anybody will have any questions, please ask. We will not get any questions. We will forward the next talk. Thank you, Doctor.
Thank you so much.
Next, we will call upon the Silas Ghana Health Service from Ghana to give her talk. Maternal risk factors for low birth weight and macromania across the sectional study in Northern Region, Ghana. Doctor? Hello.
Yes.
Yes, please
Hello.
proceed with
Can
your
you
talk.
please hear me?
Yes,
Please, can you hear me?
yes, Doc. Please start your presentation.
Thank you.
Please share
I think
your
I'll
screen.
share my screen.
Yes.
Yes, sorry. I'm coming. Please, can you see my screen?
Yes, Doc.
Hello, please, can you see my screen?
Yes, Doctor. We will share.
Thank you very
Can you
much.
please proceed with your
Mm.
presentation.
Okay. Thank you very much for this opportunity. I would like to introduce one research project which was conducted in Ghana, specifically in the northern region of Ghana. It's titled Maternal Risk Factors for Low Birth Weight and Macrosomia, a cross-sectional study in northern region Ghana. By word of introduction, my name is Silas Ejejemfi. I completed Master of Public Health in Japan 2020 at the Nagasaki University, and this was my master's thesis. I'm currently a nurse and also a researcher working in Savulugu Hospital in Ghana, which is under the Ghana Health Service. So, looking at the maternal risk factors for low birth weight and macrosomia, I just want to find out or tell you some factors from this woman that can be responsible for giving birth to low birth weight and also a bigger baby, which is also termed as macrosomia. So this will be my presentation outline. We start with introduction, talks about some study objectives, the methods, the findings, and then possibly discuss and then conclude. This is a picture showing how the data was collected. And this is one of my respondents and my research assistant. So by word of introduction, birth weight is one of the measurable outcomes of pregnancy, which is usually categorized into low birth weight, normal birth weight, and high birth weight. Low birth weight is usually called a birth weight which is less than 2,500 grams, and macrosomia, which is the high birth weight, is usually the birth weight measured equal or more than 4,000 grams. There are a lot of studies which have been conducted on low birth weight and macrosomia. And one of it is the DOHA, which is the Developmental Origin of Health and Diseases, which stipulates that these low birth weight and macrosomia, termed as abnormal birth weight, are usually associated with child death, something underweight, childhood obesity, and also adulthood non-communicable disease like diabetes and hypertension. As I mentioned earlier, These researchers also found out some association between maternal factors, including body mass index, antenatal care visits, parity of the mothers, infections, obstetrics, and hemoglobin levels, and the association with abnormal birth rate in Asia and Africa. But all these researchers are coming out with different findings, which need to also be researched on. So, few earlier studies in Ghana and also some parts of Africa assess association between these maternal factors and abnormal birth rate, particularly in semi-rural areas, despite some of the increasing prevalence rates. However, most studies do not also assess macrosomia in these areas. So the aim of this study is to identify maternal risk factors for abnormal birth rate in Sablugu municipality. The specific objectives are to estimate the prevalence of low birth rate and macrosomia, to estimate or to identify maternal risk factors for low birth rate, and finally to identify maternal risk factors for macrosomia. Methodology. The study was conducted in Sablugu municipality in the northern region of Ghana. And looking at the map of Ghana, this is the map, a sample map of Ghana, and the Sablugu municipality has been highlighted or enlarged. And we took the data from five major public health facilities, which are diary health centers in the Sablugu and also the hospitals. So the design was a retrospective cross-sectional study and a sample size of about 356 nursing mothers who have consented to be part of this study, and also are assessing postnatal health services were sampled and then they were interviewed, and some of the data were also taken from the maternal and child health record books, and the data collection was basically from February 1st to March 31st in 2022. Ethical review or ethical consideration was taken from Nagasaki and also from Ghana Health Service. So this is the outcome variables. There were two, which is low birth weight and macrosomia. And the independent or the exposure variables were 58. Out of that, we had 18 of socio-demographic or socioeconomic variables. We had about 17 anthropometry or antenatal variables, and about 23 obstetric and clinical variables. So as I mentioned, some of the data were taken from the maternal and child health record books, and this is a picture of it used in Ghana. Every pregnant woman comes with this or is given this maternal and child health record book to give data of the incidences that will occur throughout pregnancy. And this book can contain about 5 children from a single mother. So with data analysis, we started with descriptive analysis where dummy variables was created. Then chi-square and Fisher tests, as well as Wilkinson rank sum tests were done in the bivariant analysis. And after that, we used the variance, inflation factor, and also Spearman correlation coefficient to test for multicorrelationality before we did logistic regression to build 2 models for the factors or the predictors of low birth weight and also that for macrosomia. Results. With regard to socio-demographic data, male males or the male neonates were about 56%. Most of the mothers, that is about 39%, were from high-income families. The majority ethnic group was 77%, which was the Dagomba ethnic group, Ghana. About 34% of the mothers were from non-formal education sector, or they were not educated at all. And majority of the mothers were Muslims, that is, were from the Muslim religion, while 90% of the mothers were married. The mean age of the mothers were about 27 years, and that of the neonates were about 2 weeks. Now, objective 1, the prevalence of low birth weight and macrosomia. The prevalence of low birth weight was 22.2%, and that of macrosomia, or the high birth weight babies, were 8.7%. And their correspondent 95% confidence intervals has been shown. For objective 2, which was the risk factors for low birth weight, it was seen that, or it was revealed that mothers belonging to the minor ethnic groups made up of the Busa, Dagati, Ewe, and Fulani in the Savlugu municipality were less likely to give birth to low birth weight. Again, mothers who have children with height or the length less than 47.5% at birth were also less likely to get low birth weight. And again, mothers who had ANC visit, which was less than 8 visits or equal to 8 visits, were also less likely to give birth to low birth weight. And then mothers who had anemia in the first trimester of pregnancy were more likely to give birth to low birth weight, while mothers also who had anemia in the third trimester of pregnancy were about 25.7 times more likely to give birth to low birth weight. Now let's look at the risk factors for macrosomia or for the big babies. It was revealed that the socioeconomic status or the wealth contact of mothers were more likely to give birth to macrosomic babies. And again, mothers who had given birth at a higher gestational age, equal or greater than 42 weeks, were also more likely to give birth to macrosomia. So these were some of the results we had. And now, discussion. The prevalence of low birth weight is higher than the national prevalence of 10.1, which is the Ghana prevalence. And the prevalence of the macrosomia was also within the global prevalence, which is from 3 to 15%. Ghana don't have a national prevalence of macrosomia, so we have this data to give. Then the minor ethnic groups were less likely to give birth to low birth weight. And it was established that those minor ethnic groups were highly educated and the socioeconomic status were also high, which would have promoted appropriate nutrition practices, which tends to be healthy against low birth weight, and therefore reducing the risk of giving birth to low birth weight babies. Now, children whose length were greater than 47.5%, or let me say taller, were reduced the risk of low birth weight. It is established that, or most studies have also come out with that, mother's height has been reported as one of the genetic proxies for predicting newborn's length. So, in order to do so, in order to give birth to mothers or to give birth to children whose height is very good or who has very tall height, in order to prevent low birth weight, appropriate nutritional practices among these mothers must be emphasized so that it could promote greater child length through fetal programming. ANC visit, which is greater or equal to 8, reduce the risk of low birth weight. And this satisfied the 2016 WHO ANC model for positive pregnancy outcomes, because it creates opportunity for screening potential risk factors and increased content of care. That is, ANC is also very key because when a woman comes for ANC services, it's likely to be screened on daily basis. And if the woman is able to visit ANC for 8 or more, all these, it creates opportunity for all these low birth weight and other risk factors these women are entitled or at risk at. However, quality ANC services is important to promote or to reduce the risk of women developing or giving birth to low birth weight children. Now, anemia in the first and third trimesters also increase the risk for low birth weight. As we all know, anemia causes poor fetal growth. It causes less oxygen to be given to the fetus. And as a result, the fetus may not be exposed to appropriate nutrition and also other nutrients that will be needed for growth, thereby leading to low birth weights. It was also known that advanced gestational age promotes continuous fetal growth in the uterus, as most mothers who gave birth to children with a gestational age of 42 or more gave birth to macrosomic babies. So if this is happening, then the women who has higher gestational age are likely to increase the promotion of fetal growth during this extra period of containing these babies in their abdomen or in their uterus. And finally, maternal socioeconomic status was highly associated with macrosomic birth. And this has been contrasted with some studies in southern Ethiopia. So, as this should be morely investigated to find out whether socioeconomic status is actually having problem or is actually associated with macrosomic birth. Now, limitations of this study. There was a possible sampling bias as a result of some women having lost their maternal and child health record books, women who delivered in the house and also had for absence of postnatal care and antenatal care were not considered. There could be mismeasurement by non-standard method because some of the data we collected, like the birth weight and some or parity, could be less measured by these women. There could be one of the limitations was potential record bias from respondents. And as it was an interview, the mothers could have given us some false information for this study. So bias could have been, or the record bias could have been one of the issues. The data was collected at a particular season, mentioned from February to March in 2022. And that is one of the lean season, or what we call the dry season in Ghana. So seasonality could also have resulted or have affected the results of this study. Because if it was in the rainy season, there could be some prominent factors who could have also affected the results of this study. So in conclusion, knowing all these factors, anemia in the first and third trimester of pregnancy affecting low birth weight, ANC quality or ANC affecting low birth weight, and also knowing that socioeconomic status and also gestational age affecting macrosomia, it is now bound on multi-sectoral approach, which is usually applied to address some of these complex factors, because the Ministry of Health is needed, as well as the Ghana Health Service should collaborate. The Ministry of Education, the Ministry of Local Government, and also that of other development partners like World Vision, JICA, and USAID are all needed to reduce or help to prevent these maternal risk factors, which has been mentioned, in order to promote proper health being for these pregnant women in the future. For example, the Ministry of Health can educate most of their children, especially the adolescents, when it comes to the senior high school, on nutrition, so that they could prevent some of these factors. And specifically to the Ministry of Health and Ghana Health Service, we could also train and employ more of public health nutritionists to enhance nutrition counseling, and also build the capacity of community health nurses and midwives to increase their education on ANC care and ANC visits to these pregnant women in addition to promoting of their diets and other issues that can be done to prevent these abnormal birth weights. And continuous education will also be playing very important role in promoting the lifestyle of these pregnant women in order to prevent these abnormal birth weights. We acknowledge the following group of people or the institutions and organizations. Thank you very much for listening. I think the floor is open for questions. Thank you.
Thank you for your presentation, Bob. If anybody will have a question, please. We didn't get any questions. We will forward the next presentation. Now, I call
Thank
upon
you.
someone. Thank you, Doc. Now, call upon Samanthi Rath, Castro International University, Srilanka, deliver her talks on factors associated with the presence and reporting medication administration error amongst at evidence-based hospital, Sri Lanka. Doctor.
Hi everyone. My presentation is on factors associated with medication administrating errors and reporting them among nurses at Tavisa Vela-based hospital, Sri Lanka. This is my presentation outline. Patient safety is a significant challenge in healthcare setting. Medication errors are widely reported and it mainly contributes to patients' health safety. Medication errors are possible at each step of handling. Medication administrating errors and prescribing errors are more common. Concerning medication administrating errors contribute to 2 to 14% among hospitalized patients by nurses. It is estimated that 70,000 of deaths and 1.5 million injuries due to the medication administrating errors. Nurses spend 40% of their time handling medicines. Safe medication administration and rapid detection of medication administrating errors are key roles in nursing profession. Related guidelines and policies are well established, mainly included 3 checks and 5 rights. Recently, 10 rights also established. Those are included: right patient, drug, dose, time, route, assessment, approach, interactions, information, and documentation. Despite the availability of well-established drug administrating guidelines and possibility of prevention of medication administrating errors are still widely reported in healthcare setting. Reportedly, more than 70% of errors result in adverse health outcomes among patients due to the negligence and failure to reporting those errors. So, identified common contributing factors for medication administrating errors are unfamiliarity with drug and drug administrating protocols, administrate without rechecking, work pressure, communication errors, medication packaging, transcribing errors, and barriers that lead to follow the medication-related guidelines, and also failure to be alert during drug administrating process. Reporting medication administrating errors also equally important similar to prevention of medication administrating errors. However, medication administrating errors are underreported. Identified common factors that contribute to not to report to medication administrating errors by nurses are fear to consequences, loss of job, professional license, disciplinary action, and inability to identify the medication administrating error, negative feedback, administrative response, time-consuming procedures. Having time-consuming procedures in reporting are also identified factors that contribute to medication administrating errors. So, current study was aimed to assess the factors associated with the presence and reporting medication administering errors among nurses at Avisavela Base Hospital, Sri Lanka. It was a descriptive cross-sectional study conducted among 300 nurses who are involved in clinical nursing activities with handling medicines. We used simple random sampling method and pre-tested self-administered researcher-developed questionnaire consisting of baseline characteristics, 34-item 5-point Likert scale to assess the factors contribute to medication administering errors, and 20-item 5-point Likert scale to assess the factors contribute to reporting medication administering errors. Data was analyzed by using descriptive and inferential statistics using SPSS version and Minitab. The study was ethically approved. Moving to most important part of the study results, majority of nurses were female, Sinhalese, married participants, and also educated about the diploma level. Mean age was 36 years and mean working experience was 12 years. Furthermore, they handle average of 32 patients per day. And also average night shifts per month were 9 shifts, and also average sleeping hours were 6 hours. Data related to factors contribute to meditation administrating errors and reporting meditation administrating errors were reliable and satisfied with the reliability and validity requirements. So, concerning the pre-checks, before administering a medicine, we have to pre-check. We have to check medicine, compare the medicine label, drug label with the BHT, medical orders. So we evaluate this. Concerning this, 95% nurses read the BHT, medical orders, medical instructions, clinical records of the patients. And also 92% recalculate unclear doses. And also, first check was done. Compare the drug label with BHT before taking drugs from its container was done by 90%. However, concerning second and third checks were reported less proportion compared to the persons who did the first check. And also we evaluate the adherence to meditation administrative rights. So concerning 8 rights, 99.7% administrate meditations to correct patient. However, concerning the indications of medicine, indication of administrating medicine and checking the response after the administrating medicines were reported in less proportion compared to the nurses who followed other 5 rights: right patient, drug, dose, time, and route. So concerning the common factors that contribute to meditation administrating errors were included poor communication, having verbal orders to administer drugs, having medical abbreviations, unclear physician's order, and also similarities of medicines, similarities of packages, as well as clarification doubts from peers, other nurses, equipment malfunctions, and not having enough time to administer medicines to all patients in the board, a staff shortage, multitasking. Also, patients are on similar medicines and patients are having similar names were the commonly contributing factors for meditation administrating errors. Concerning those 34 items of questionnaire that used to meditation administrating errors, we carry out factor analysis. So factor analysis reported 9 factor solutions based on the principal component analysis and variance with Kaiser normalization. So those 9 factor solutions that lead to meditation administrating errors are included: physicians, pharmacist and drug list related factors, similarities of medicines and packages, work pressure, personal factors, communications, insufficient knowledge and insufficient training on safe drug administration, physician related factors, unclear dosing and substitution of drug list, and clarified doubts from peers were the common factors that derived from 34-item questionnaire. Accordingly, higher mean values of each common factor indicate commonly contributing factors. Accordingly, pharmacist and drug-related factors, work pressure, personal factors, and insufficient knowledge and training were highly contributing factors for meditation administrating errors by nurses in Sri Lankan setting. Furthermore, we evaluate the associations between selected baseline characteristics and common 9 factors. Accordingly, age and working experience were associated with all common factors except the having knowledge deficit. Furthermore, we observed many associations between the length of work shifts, sleeping hours, number of night shifts with the variety of common 9 factors. Then we evaluate the factors contribute to reporting meditation administrating errors. Accordingly, fears of blames, fears for consequences, and having negative attitude from patient, family, administration, and also having individual influences rather than concerning the medication error and finding a better solution. And also reporting is time-consuming procedures were the commonly contributing factors to reporting meditation administrating errors. Furthermore, 50% reported that they report the meditation administrating errors if it doesn't harm to patient. So again, for that 20-item questionnaire that used to assess the reporting factors contribute to reporting meditation administrating errors. Conducted another fact analysis for that questionnaire, and fact analysis reported 5-factor solution that contribute to meditation, not to report meditation administrating errors. So those common factors are fear, administration-related issues, attitude, knowledge deficit, and negative impression. Concerning the mean values of those common factors, highly contributing common factors were the fear, administration-related issues, attitude, and knowledge deficit. So associations were observed between the factors contributing to meditation administrating errors and selected baseline characteristics. So concerning this, age was associated with all common factors and working experience was associated with the 4 common factors except the administrative related issues, and many associations were observed between selected baseline characteristics and identified common factors. Education level was associated with all common factors of reporting meditation administrating errors. So moving discussion. In current study, poor communication, having verbal orders, medical abbreviations, unclear physician orders, similarities of packages and medicine, clarification doubts from others, equipment malfunctions, time pressure, and multitasking are the commonly contributing factors for meditation administrating errors by nurses. Furthermore, concerning the common factors also, physician and drug-related factors, personal factors, work pressure, insufficient knowledge and training on safe drug usage, drug administrating are contributing to medication administrating errors. Furthermore, many associations was observed between common factors with the age, gender, education, I'm sorry, there was a cut in my area. Now it's okay. We can continue. I'm extremely sorry regarding that. And also, those findings were very similar to current study, as well as 9-factor solutions also reported. And also individual factors for 34 item scale also reported similar findings. So concerning the meditation administered in years, those are underreported. In current study, we didn't evaluate the prevalence of meditation administered in years. However, in current study, we identified many contributing factors for not to reporting meditation administered in years. Those were blames, adverse, and individual influences rather than finding better solution for the error. So, furthermore, fear and all fear and other variables, fear of the consequences was associated with age, gender, education level, working experience, and number of patients in unit and nurses. Many associations was found between the meditation administered in years and selected baseline characteristics. Concerning the similar findings were reported in Saudi Arabia also. Time-consuming procedure. Reporting is a time-consuming procedure having individual influences, negative feedbacks, and blinds were common not to report meditation administered in years. However, association was not found out. Association was not found out in those reported that nurses are reporting meditation administered in years. By 67% of nurses are reporting meditation administered in years if it is not severe. Even in current study also, 50 nurses reported that they are reporting meditation administered in years if doesn't do harm to patient. Not to reporting serious meditation administered in errors may contribute to serious health consequences and death of patient. Thereby, reporting all type of meditation administered in errors are very important. So I would like to conclude it that legibility of medicine order, medical orders, medical appropriations, similarities of packages and medicines, time pressure, staff shortage, multitasking, poor communication, having verbal orders are the commonly contributing factors for meditation administered in years. Nurses' age, working experience, education level, length of duty shifts are associated with the factors that lead to meditation administered in years. Furthermore, night shifts, sleeping hours also contributing to associated factors with the meditation administrating errors. Meditation administrating errors are underreported. Fears, blames, adverse consequences, negative feedback, and administrative responses are highly contributing factors for reporting meditation administrating errors by nurses. Furthermore, fear of consequences were associated with age, gender, education level, and working experience, as well as number of patients and number of nurses in the working unit. So I would like to recommend periodical studies to assess the prevalence of meditation administrating errors, type of meditation administrating errors, and also to assess the further associated factors, also identify the associated factors usage, safe medicine administration, and also to minimize the contributing factors for meditation administrating errors. Furthermore, we have to encourage the reporting meditation administrating errors and minimize the barriers, factors that lead to meditation, not to reporting meditation administrating errors. Educational interventions, training programs, awareness sessions, further research may be effective for that. So those are the references. Thank you. Have a nice day.
Thank you for your presentation. And if anyone has questions, feel free to ask. We didn't get any questions. Thank you for your presentation.
Thank you.
Now I call upon Dr. Elvira Lens Continence and Stomach Care Austria to deliver talk on entrance gate or gems. Doctor, please share your screen. Miss Elvira, can you hear me?
Yes, I can hear you. You hear me?
Yes.
Okay.
Please share your screen.
I make it. So, hope you hear me and you see my
Ye-
presentation.
No,
You can't see?
we can't see your presentation.
Okay. I tried another one.
Yes,
Yes.
yes. Now you can post.
Okay. So, my name is Elvira Habermann. I'm pleased to be attending this event. For more than 20 years, I've been working as a mobile freelance consultant in continence and stomach care. And in this time, I've often observed problems with catheters that can lead to serious issues. Today, I would like to share my knowledge and observations. And before I start, I would just like to thank my colleague and co-author, Karin and Philip, for all their help and support, without which I would not be here today. Now let's get started. I'm sure many of you will recognize this situation. I'm here to talk about how we can prevent such problems with permanent catheters. Let's look at the facts. Every catheter also represents an entry point for bacteria. This may cause a catheter-associated urinary tract infection, which in the worst case could also lead to urosepsis. And carers are continuously confronted with this problem. And here are the points of entry. The first possibility is, of course, already during insertion, from the area to the meatus and the distal urethra. Next eventuality of entry is between the urethral catheter and the mucous membrane. And finally, by way of retrograde protection from a contaminated urine bag or from a urethral catheter after disconnection of the closed urine diversion system or use of an unsuitable system. Further disadvantages are blockages, fistulae, stenosis, and strictures. And here are the chemical and mechanical aspects. There's a mechanical irritation from a urothelium. The pressure from the catheter on mucous membrane leads to local vascular disorders and weakening the microbial human status. The catheter hampers the secretion flow of urethral glands. And they are the biofilms, so-called mucopurulent membranes. They are the site of secretions and cell detritus. And surface incrustations promote the formation of biofilm as an adhesive base for bacteria and cause additional mechanical irritation. And at last, the chemical irritation of the urethra epithelia from the substances emitted from the catheter material. Now we have a look at the process. Bacteria in the urine, like Proteus mirabilis, produce an enzyme named urease. This splits urea into ammoniac and carbon dioxide. We found an increase of urine pH value. It leads in alkaline, and these are the ideal conditions for the development of crystals. Let's look at the urease activity. The acidification in the presence of urease leads to an initial decrease of pH value. But with further addition of acid, it quickly returns to an original alkaline value. pH value 8 to 9 causes massive increase of the urease activity. And this is detrimental and ineffective for the patient. So incrustations are not prevented, but promoted. For this, please note no additional acidification. The germ Proteus mirabilis has got very high urease activity. It is the main cause of persistent incrustations. These are mineralized bacterial biofilms. The urease of this bacterium hydrolyzes urea 6 to 10 times faster than urease of other species. Proteus mirabilis spreads quickly by forming swarming cells. These are accumulations. And Proteus mirabilis detected in obstruction material of almost all catheters. And here are the resulting problems. There are incrustations on the catheter surface and tip. You see it before on the picture. There are high sediment columns in the lumen. There are blockage of the permanent catheter, and this triggers the catheter obstruction with an ascending urinary tract infection within a few days. There are frequent catheter changes, maybe 2 or 1 time in week, and a pain for the catheter patient, as well as huge costs for the health system. Now we look to provide guidelines. The first, the urinary diversion system management. To choose the right system, we should differentiate between mobile or bedridden patients. But always we only use sterile closed systems. For bedridden patients, we need a bowl with a capacity with 2 liters, and the safety factors: drain cock, urine sample extraction point, drip chamber with bacteria filter, membrane check valve, and a longer drainage hose. And for this, it's worn for longer periods. And there is another option for the mobile patients, the so-called slack bag. These should be only used for mobile patients. It has not so much safety factors, and for this, it has shorter change cycles. Please always have a look for the guidelines from the companies. And indispensably is a free flow, no tension on the hose. A bag or drainage nozzle must not get into contact with the floor or anything else. And please installation the bowel below bladder level and evacuation the urine before it reaches the non-return valve. Excessive manipulation rapidly causes intraluminary bacterial ascension. Within 4 days, we find 100% bacteriuria. Now the change cycles from the urine diversion system. There's no general uniform procedure, either in literature or in practical experience. There are varying products in different institutions and countries. And the change cycle is prescribed by the companies based on the Product Liability Act. Here we find the maximum varying from the system. And don't forget the unsightliness and odors. They are very uncomfortable for people participating in an active social life. Now, how to handle it? Why the point of connection with a sterile alcohol swab? This is the mechanical disinfection, and it eliminates effectively the germs. And don't forget the exposure time. In extramural setting, we don't have a sterile scissor always available. For this, we use leg bags with fixed length drainage hose if we find mobile patients. And for more capacity during the night, plug the non-sterile night bag into the drain cock and detach, evacuate, and discard in the morning. And the further variation to provide the option of being free from urine bag during the day from mobile patients is the catheter 5. For the maximum varying, we look at the Product Liability Act from the companies. And please observe the contraindications here. The patient should be able to empty the bladder on a regular basis. And for a good night's sleep, plug the non-sterile night bag into the valve. Catheter change cycle when required. Now, we should know also here the maximum insertion period from the industry. If we have silicone material, the catheter can stay to 6 weeks. For me, I organized the first change early enough after 4 or maximum 5 weeks. After I look for the conditions from the catheter tip and surface, and this determines the subsequent change cycle. And if I need it, I adapt it. An encrusted catheter tip is changed with an encrusted catheter tip. The change is painful for the patient and the uterine mucosa will be injured. And after 4 weeks, we also find here unpleasant odors from the biofilms and deposits. We always should focus on extending the life cycle from the catheter for frequent changes. And for this, you find out the reason. So in short, we should define individual instead of rigid change intervals. If you're planning a catheter outlet, you sure have the first look at the anamnesis, and the physician and care person should conference together. After the spontaneous mixtures, you make repeated residual urine control, preferably in the afternoon, because these prevent a nightly renal shutdown. Before catheter outlet, to make catheter clamping for bladder draining, this is obsolete and can initiate and catheter-associated infections and complications. And note, if we find urine leakage beside the catheter, the problem is not low area or insufficient balloon blocking. The reasons are spasms of the bladder from an irritation and or urinary tract infection, or we have blocked catheter eyes. Now the care, catheter maintenance, only daily cleansing of the urethral orifice, the catheter, and the genital area with water and soap. And a regular application of antiseptics leads in massive skin irritations. For this, stop it, please. And what we make, if we have frequent catheter changes and we find incrustations. First, clarification with an urine culture and resistance determination. After, a specific antibiotic therapy for a sufficiently long period of time. 24 or to maximum 48 hours after the beginning from the antibiotic therapy, we must make a catheter change, because otherwise we find a reinfection from the bacterial biofilms into the bladder. And if the process wasn't successful, the symptoms stay on, we must repeat the process. In my knowledge, I've seen 2 or maximum 3 processes after we can eliminate the Proteus mirabilis. And bladder irrigation is only conducted in case of special urological indications. The first, internal irrigation, a sufficient amount of liquid. And complications by irrigation with a bladder syringe and sterile natrium chloride solution, this is not recommended, because we find problems in handling of floating, disconnection, and the incrustations are flushed into the bladder and the sediments settle on the floor. And for this, we find more and more and more problems. Please only use sterile, ready-made, dispensable irrigation solutions, like, for example, Urethana. Here we have 2 options. The first is the Urethana Sovigi, with a reaction time from 5 minutes, please. It dissolves incrustation, reduces the pH value, and minimizes the bacterial contamination in the bladder. And the next option, The next option is urothiana polyhexanide, immediate drainage without reaction time. And this serves to prevent catheter-associated urinary tract infection, short COTI. Now my very short take-home message. Please look for the correct management from permanent catheters. When problems occur, analysis of causes and specific therapy. Thanks for here. Thanks for your attention. If you like to know more, you find my article in my website. Entrance Gate of Germs is the article. And now I wait for questions. Thanks very much.
Thank you very much for your introduction. If anybody have any question, please ask regarding this presentation.
Thank you.
Anybody ask any question? We didn't get any questions. We will forward the next presentation. Thank you so
Okay.
much for your presentation.
Thank you too. Bye-bye.
Bye. Now we call upon Miss Leela Pennant, Researcher, Iran. The title, to deliver his talk, the effective, immediate, and which inspiratory muscle training on rehabilitation of low back. Miss Leela, can you hear me?
Hi, yes, I'm here. Do you hear?
Can you share? Yes, we can hear you. Can you please share your?
Okay, I'm sharing my presentation. Okay. Okay. Sorry, could you share my PowerPoint?
Okay, we will.
Thank you. Okay. Shall I start?
Yes.
Okay, greeting for all the audience. I'm so honored to participate in Nursing and Advanced Healthcare Conference. It's better, before to start my presentation, it's better to introduce myself. I'm Leila Ahmadnejad, PhD of Physical Education and Sport Sciences. My presentation topic is the effect of immediate and 8 weeks inspiratory muscle training on rehabilitation of low back pain. Please have an overview of my presentation. Okay. Chronic low back pain is one of the most common musculoskeletal disorders that affected average of 4% to 33% of individuals. Chronic low back pain also affected quality of life and led to disability and absenteeism. And approximately 85% of the low back pain cases are described as non-specific low back pain due to the lack of compatibility between their symptoms and radiological findings. These diseases also are so prevalent between the aesthetics, and the prevalence rate in aesthetics range from 1% to 40%. Okay, there are so many factors that cause this disease. Factors such as joints, intervertebral discs, tendons, ligaments, and muscles can individually play a major role in progression of this disease. You can imagine, for example, one of the local muscles is transverse abdominis muscles that is so important in these people and in all the people. And if this muscle's activity is delayed, the activity of another global muscles increases in some cases, and vice versa. Another factor is multifidus muscles. This is the other local muscles in core of the body, and atrophy of these muscles led to reduction in muscle size and resulting alternation in muscle contraction in individual with chronic low back pain. Okay. In this picture, you can see the position of the respiratory muscles in the body, and there are some transverse abdominis local muscles and another local muscles, multifidus, that you can see in these pictures. Okay. In this slide, you can see core and respiratory muscle synergy. That if you focus on this picture, you see the multifidus muscles and transverse muscles also have a core responsibility in the body, and also respiratory muscles responsibility, and they are co-contraction with each other. Okay. The purpose of our study was the immediate and 8 weeks respiratory muscle training on selective local and global muscles activity. We had 2 hypotheses. IMT affected electromyography variables in aesthetic with non-specific low back pain, and IMT affect the pain intensity in aesthetic with non-specific low back pain. The present single-blind randomized control trial conducted accordance with Helsinki and approved by Ethic Committee of Medical Science. Okay. Please focus in these pictures. This figure presents the flow diagram of the study. The sample size was 24 for each groups, and we used the G-Power software to select the subjects, and we randomized these subjects into 2 groups. And also, it's better to mention that we use randomized allocation systems to randomizing the subjects into groups, IMT groups and control groups. And the randomizing was done with one of the research team, therapist of one of the research team. Okay. Okay, you can go to the next slide, please. Our study has some inclination criteria. As I said before, all the subjects were the aesthetics, and this aesthetics must have a low back pain, and their low back pain must persisting for approximately 3 months, and they must performing continuous and regular exercise, and they didn't have any orthopedic or neurological disease. In this slides, you can see our variables. Independent variables was IMT, and dependent variables was local and global core muscles activity and pain severity. Because we study our subjects was human before they entering this subject to the lab, the participant studies the written consent form and then sign it. Okay. Okay, in this slide, you can see our facilities and research tools, and it is better to explain another instruction to the subjects we had done, and after that, I will explain our facilities. We have a meeting. We have a meeting with our subjects, and the subjects we said for them the instruction. Some of the instruction I'm mentioning it here, and the subjects were prohibited from performing intense exercise 2 days before the study. They had performed no physical activity 20 hours before they study, and they were also forbidden from consuming caffeine from before the test, and were instead encouraged to have a sleep 7 hours before they study, and they eat their last meal 2 hours before they study. And it's better now to explain our facilities. In the previous slides, you see the flexible rulers. The flexible rulers was measured for lumbar arch. And in these slides, you see visual analog scales, and we use these scales for VAS measure. And as you can see, this is the range of from 0 to 10, and high scores indicated a higher intensity of pain. Okay. These are skin tags, and these are surface electrode that we use for the measure the activity of the muscles. Okay. As for first, electromyography devices was used to record the muscles activity in both groups, IMT groups and control groups, during the overhead squat movements with statics and dynamics. You see that the subjects, one of our subjects, that doing the overhead squats, and we use the electromyography to record their activity of body. As you see, we measure the muscles activity in these figures. Why we use this exercise for measuring the activity? Okay, I'm going to explain the overhead squats. The overhead squats, as you know, is a functional movement screen and a method used in rehabilitation that requires strength of the trunks and muscles, and also need balances to mention when moving. Okay, performing this movement needs to coordination and the entire kinetic chains and kinetic chains. It's better to explain the duration of the overhead squats. We measure the muscles activity in overhead squats in 2 phases. Static squats and also dynamic. Static squat was, please go to next slide. This is electrogoniometry, and in this in the phases of the static squats, we use an electromyography placed at 90 degrees on the lateral knee, and was used to control the angle of the knee. To the dynamic test also had a descending and ascending phases. The duration of the phase was 4 seconds. 2 seconds was ascending and 2 seconds was descending phases. Also, it's better to say that this movement speed was also controlled via metronome at 30 beats per minute. You can see in this slide the electrode placement. As I mentioned, we selected 4 muscles, 2 locals and 2 global muscles. Rectus abdominis and electrospine were our global muscles. Transverse and multifidus were our local muscles. And in this slide, you can see where to electrode placement. Okay. This is a KH1 power brace devices that for inspiratory muscle training, and the experimental groups use these devices to have their intervention. As my topics was the immediate and 8 weeks respiratory, because of lack of time, I only explain a summary of the immediate respiratory muscle training as you see in these slides, but I'm going to explain the 8 weeks respiratory muscle training in generally and completely. Okay. The 8 weeks in intervention instruction were as follow. First, each experimental subjects, okay, experimented with power brace and were introduced to training program with power brace by a therapist and instructional session, and then practice with these devices. In the first session, the patient were in the sitting position and upright the upper extremity, and they have a deep braces, and before that they're familiar with these devices, and they get into have an IMT to 50% of their maximum inspiratory pressures, their PI max, and the overall intensity was gradually increased. The training pressures was also increased by 5% per week to maximum of 90 of PI max. And the experimental groups did the 50 breaths per minute, 30 breaths per session, twice daily, and 7 days per week. This was our intervention, 8 weeks intervention. Okay. The EMG data were analyzed by MATLAB software. As you can see in the slide, we use this formula, co-contraction formula, to measure the co-contraction of local muscles and global muscles. We use these formulas that in the end of these slides. Okay. This is our statistical analysis, that the repeated measure analysis of variance and one-way variance of covariance were further used to compare intra-group and intergroups, resulting follow the intervention. Okay. In these slides, you can see subject characteristics that, as you see, we selected in both gender, men and women, and the age, height, and weight, and BMI, lumbar arch, and other factors that you can see in these slides. Okay. Go to the results of our study, and in the pre-test and post-test, we measure the muscles activity, co-contraction, and pain intensity. These were our independent variables. The results shows that the EMG activity findings from the intragroup and intergroup in the statics test and dynamic test in both phases revelated that the activity of rectus abdominis, electrospinous, and co-contraction of global muscles decreases significantly in the experimental groups. And another factors, transverse abdominis, multifidus increases in a significant manner in experimental group. Also, co-contraction of local muscles was significantly increases in experimental groups. Please go to the next slides. Moreover, there was a significant difference in activity of electrospine, multifidus, rectus abdominis, and transverse abdominis and co-contraction rate in the local muscles and global muscles between the experimental groups and control groups. You can see our data in these slides. Okay. These slides show the results of descending and ascending phase and the activity of muscles. Okay, please go to the next. As you can remember, under other independent variable was pain intensity. Moreover, the decreasing trend was observed in the visual analog scales in experimental group. As you can see, training groups and control groups that the decreased after the IMT was appeared in the training groups. The results of this study indicated that IMT had increased the activity of local muscles and co-contraction of local muscles in overhead squats, also in static overhead squats and dynamic in both phases. Okay. Before us, some researchers had some experimental, some had research in this respect, such as Hodges and their colleague, and they said that the respiratory muscle training led to increase the activity of local muscles, but this is not always remarkable. When the load of the training was increased, the activity of trunk local muscles remarkably increased. Another study that Hodges and their colleague and Makado was done that they used some exercises, respiratory exercises and breathing exercises, yoga or diaphragmatic exercises, and they for the patient of low back pain, and they said that this exercise improve the stability of intervertebral joints and increases motion control in patients with low back pain. And another study that we can mention for it, Marshall and their colleague, that said that respiratory exercises led to increase in activity of rectus abdominis and transverse abdominis and external oblique in patients with chronic low back pain. Now, why the pain intensity was decreased in experimental group? We decided that the increase of local muscles activity and co-contraction of these muscles can both be taken a factor that lead to reduction of pain intensity in patients with these individuals. Why, now it is a question, why the IMT led to increase the activity of local muscles. We discussed about this problem, and we mentioned that maybe changes in motor control units from the random mode before performing IMT, inspiratory muscle training, to synchronized mode after IMT led to increasing the activity of local muscles. And another factors, maybe IMT led to thoracoabdominal nerves stimulated with IMT, and after stimulated this nerve, this led to increase the activity of local muscles. As a solution, according to the results, the present study showed that IMT can increase the activity of local muscles in athletic with chronic low back pain, thereby reduce the pain intensity in these individuals. Our study had some limitation, as you see that the sample was just a young athletics with a range age of 18 to 25, and all the subjects were in this population, and we all of them was athletics, and we measure the muscles activity just in the figure of the overhead squat, not in motion or in relaxed position or another one. Implication of these muscles, this exercise, since this exercise are easy, accessible, and sport therapists, rehabilitation cares, and physicians and trainers are recommended to use this exercise to reduce pain intensity in athletics or another population of that suffer from low back pain. We have some publication of this study. A recent publication I can mention about the one of our papers was published in sport rehabilitation journals. Another was published in applied biomechanics journals, and another one was published in Journal of Kerman Medicine University Science. Okay. Thank you for attention, and if you have any question, or as I am independent researcher, one of the researcher or assistant are honored to participate or do in this respect. I'm so eager to participate with them. And if you have any question, this is my email address, and you can send the email and I will answer you.
Thank you for your presentation. And if anybody have questions, please ask it. We didn't get any questions now. Thank you for your presentation. Now I would like to propose 10 minutes break for short break. Now after we will continue meeting.
Thank you for this conference. I'm so honored to participate in this conference.
Thank you.
Thank you. Have a good time.
Welcome back. Then now I call upon Joseph University of Namibia to deliver talk on clinical learning experience of nursing degree students at the training hospitals, Comas, Namibia. Doctor, can you share your screen?
That's all.
Yes.
Good afternoon. We just share the screen.
Share your screen.
Just a moment. I'm looking for the screen. I'm having trouble loading the screen. See my screen?
Yes,
Yeah.
we can.
All right.
Yes, you
Good
can.
afternoon.
Yes.
I would like to thank the organizers of the conference for the opportunity. My name is Galukeni Kadila. I'm a lecturer from the University of Namibia, and my topic is clinical learning experiences of nursing students in the Comas region. I'm a lecturer from the University of Namibia, and I am lecturing nursing students. Clinical placement provides an opportunity for socialization of students in the health system, and also provide an opportunity for them to acquire practical clinical skills in real life setting while observing the deliverance of care by other health workers. Despite the obvious benefits of clinical placement for students, poor relationships with the professors and nurses, and environments that fail to promote belongingness and the lack of supervision hinders learning in the clinical setting. The aim of the study were to explore and describe the clinical learning experiences by nursing degree students in the general wards at the public training hospitals in the Comas region, Windhoek, Namibia. The study, the researchers selected the qualitative, explorative, descriptive, and contextual design, and 71 participants from the undergraduate, second years, third, and fourth year were recruited. Data collection included 11 individual face-to-face interviews and also 8 focus group discussions using a study-structured interview. Data were manually coded and analyzed using the text method of data analysis. Let's continue the results. So 4 themes emerged from the study. Those were non-conducive learning environment, negative staff attitude, communication as a barrier, and also shortage of staff members. So, conclusion, it was concluded that there were limited learning opportunities for the nursing students in the clinical setting in all the levels of year studies. The study revealed that students encountered several constraints during their clinical placement that negatively affected their clinical learning during their placement. Some of the negative experiences included overcrowding in the wards, resulting in to reduce learning opportunities and frustrations in the clinical setting. Further, The participants also agreed that staff shortage affected their nursing students negatively, as all participants mentioned that they were not taught or demonstrated to, and were also working unsupervised. That was dangerous. They also felt that they were overworked. The participants agreed that this experience made them work under fear of making mistakes and also risking their own education as they had minimal skills to practice. In the same vein, the students also showed their dismay on the fact that some nurses don't know how to communicate, and they were just shouting and screaming on them in their clinical area, which affected their clinical learning in a negative way as they missed out on important morning reports and teaching opportunities that were done in a non-official language as they were not understanding the other languages. The experience made them feel isolated, discriminated, and demoralized and unwanted in the clinical setting. Will be all from the presentation. Let's stop sharing and welcome the questions.
Your presentation. If anybody have any questions, please ask regarding this presentation. We didn't get any questions, Rob. Thank you for your presentation.
Thank you so much.
The next speaker has not joined yet, but we do have her video presentation. So I would request you all to just have a look at it, and maybe she will be joining at the end of the session. Thank you for bearing with us. You unmute.
Hi, everybody. Hope you are all fine and safe. I'm Professor Iman Salman Baya, Professor of Nursing Administration at the Faculty of Nursing, Salwan University, Cairo, Egypt. First of all, I want to thank the organizing committee for inviting me to participate at this valuable conference, which brought us together from global perspective scientists and researchers and from several backgrounds to exchange our ideas, advance knowledge, and discuss key issues for nursing. My presentation today is about emerging of clinic hospitals in the future challenge for nurse managers, designing and validating protocols. My agenda for this presentation, I'm going to give you an introduction about this aim of the study, research hypothesis, methodology, results, conclusions, and recommendations, and finally the summary. First of all, in this with rising average temperature across the globe, it causes increasing sea levels as well as extreme weather around the globe, threatening our health, environment, and socio-economic development. Climate change is a reality, and the modern healthcare sector not just contributes toward this great phenomenon, but itself is being affected by it. The WHO also pointed out climate change affects the fundamental requirements for health. Climate change is not only an environmental or financial problem, but also a health problem. WHO also added that over time, climate change is increasing the burden of global disease occurrence. More and more evidence shows that rising temperature provides an easier channel of infection and makes infection spread out, resulting in the increased number of deaths. Health sector can play a vital role in mitigating climate change. As members of the WHO's Health Security and Environmental Cluster wrote that the health sector is one of the most trusted and respected sections of society. It's also one of the largest employers and consumers of energy. This presents both a duty and a window of opportunity to achieve climate neutrality, efficiency, and cost reduction, all at the same time. Significant contribution to their communities by providing a wide variety of services, also consume a large amount of energy in providing healthcare. Also, they operate all day, every day, making their environmental footprint large in many communities. Hospital management should focus on ways to minimize of non-toxic products, recycled use products, and proper waste disposal techniques. Despite the great societal implications of climate change, Egypt is one of the leading countries with the fastest rate of greenhouse gas emission, and is expected to double the rate of emission by 2030. As you know, that Egypt conducted or hosted the COP27 for climate change the last November, and at that great event, Egypt announced that the Sharm el-Sheikh International Hospital was transformed into Green Hospital. Regarding the aim of this study was to design and validate protocols for greening hospitals in selected hospitals, to assess managers' knowledge about green hospitals in selected hospitals, raise managers' awareness about green hospitals, assess practice green health as perceived by managers in selected hospitals, design protocol for greening hospitals, and examine the validity of the design protocol. While regarding the research hypothesis, it was hypothesized that most managers will lack knowledge about green hospitals. Also, there will not be a protocol for greening hospitals in the selected hospitals. Subjects and methods. The research design of this study was a quasi-experimental study. The study was conducted in two private, internationally accredited hospitals at Cairo, Egypt. So the subject of this study consisted of two groups. The first group included all managers from all business levels. Other one, including top manager, middle and functional level, or the first line manager in the selected hospital. Furthermore, quality manager, custom control manager, human resource management, financial manager, health and safety manager, housekeeping manager, and so on. Both male and female managers with at least 2 years of experience were included in the study. The total number was 112. By the second group of this subject, this group served as a panel of experts. There were 45 professors and assistant professors from faculties of nursing as Egypt, in addition to experts from American University in Cairo, because the American University of Cairo had established the Office of Sustainability as a center for applied research on the environment and sustainability. So a panel of experts from this center was included. They were 15. The American University in Egypt has taken several measures to foster a clean and green campus environment, from developing a sustainable trash management system and building the university's first extensive green room. As you see here in this table, the distribution of study samples according to hospitals. From the first hospital at 58 were included, while from the second hospital 44 were included in this study. The total number was 112. Regarding tools of data collection, 3 tools were used for data collection. The first tool was manager's knowledge about green hospital questionnaire format. The second tool, green hospital checklist, and the third tool was questionnaire format. The first tool, it was a self-administered questionnaire designed by the researcher and used to assess the selected manager's knowledge about green hospitals. It included questions as definition of green hospital, its elements, importance, and barriers for creating green hospitals, and so on. While the second tool was Green Hospital Checklist, this tool also designed by the researcher, it was used to assess the practice of green hospitals, green health as perceived by managers in their hospitals. While the last tool was the engineer sheet, this was used to also was designed by the researcher to elicit opinions regarding suggested green hospital protocol. Regarding the pilot, the researcher conducted the pilot study, and you know that the aim of the pilot study is to test the practicability and create the time needed to complete study tool. 10% of the study subjects were included in this pilot study, and based on the pilot study, no modifications were required, so all of the subjects were included in the entire sample. While regarding the administrative and ethical considerations, sure, before study conduction, approval was obtained from the Scientific Research Committee at the Faculty of Nursing for the researcher, and letters containing the aim of the study were directed from the same faculty to each hospital general manager to obtain their permission and help to conduct the study in their facility. Also, the researcher met the subjects and explained for them all things regarding the study and obtained their written consent regarding their participation in the study, confidentiality, anonymity, and the right to withdraw from the study at any time where granted. So, the main reason of this study is that this table shows a certain distribution of managers' knowledge about green hospitals before and after awareness sessions. As you see here, that most of managers, 91% of them had unsatisfactory knowledge about green hospitals. Meanwhile, only 2.7% of them had satisfactory knowledge before awareness session. Compared to post-awareness session, the majority, 86.6% of them had satisfactory knowledge, and only one manager had unsatisfactory knowledge. So there was a highly significant difference between managers' knowledge about green hospital before and post our discussions. While this figure reveals the distribution of total scope of practice green health as perceived by managers. It was observed that, as you see from this figure, that more than 50% of the managers perceive poor practice of green health, while only 11.6% perceive good practice. This table, I was divided into two tables because it's a long table. As you see here in this table, percentage distribution of managers' agreement on suggested steps of green hospitals. They agreed upon the steps of look at the climate change as a healthcare issue, design green buildings, sustainable use of natural resources such as water and energy, change hospital meal options, provide healthy food, apply sustainable waste reduction and management, purchase green cleaning products, reduce transportation costs, apply green resource management, use alternative means of energy generation. As you see here, that this table indicates that about all of managers accepted the suggested steps of cleaning hospital protocol, and there was no significant difference between the two of the study hospitals. As you see here, this table is very long, so I divided it into three parts. The first part shows the steps of green hospitals, starting from looking at climate change and healthcare and to the end, use alternative means of energy generation. While the second part was regarding the just time used in the protocol regarding the clarity, correct, scientific, and sensible, comprehensive, and acceptable. While this part of the table shows that the protocol covers all dimensions of these hospitals, and the protocol is free from any duplication or redundant items, there is a balanced among various dimensions of the protocol. The protocol is in a logical sequence, and it can be used for orienting newly appointed managers and can be used for guiding already appointed managers and useful for training hospitals for course. Protocol can improve organizational plans, image, and competitive advantage. As you see from this table, which was divided into three slides, into three parts, as I mentioned before, all the jurists agreed upon the design protocol, while only 97% of them asserted that it was free from duplication and redundant items. Also can be used for guiding the already appointed manager. In addition, 95% of them emphasized that it was in a logical sequence, could be used for orienting newly appointed managers and useful for training hospital workforce. So, finally, we are here for the conclusion. The conclusion of this study contributes to shedding new light on emerging of cleaning hospitals as a future challenge for nurse managers. The study assessed managers' knowledge about green hospitals in the selected hospitals. Most of them had a satisfactory knowledge level about the green hospital. Awareness sessions were conducted, and in post-awareness sessions, most of them had satisfactory knowledge, and only one manager had unsatisfactory knowledge. The study also analyzed the practice of green health as perceived by managers. The study found that more than half of them perceive poor practice of green health, while only 11.7% of them perceive good practices. Based on the previous results, the researcher asked directly if there is any guidelines or protocols in the selected hospitals about green hospitals, and the answer was no. So the researchers suggested steps of reading the hospital protocol. Almost all managers accepted the suggested steps of reading the hospital protocol. Finally, the researcher examined the validity based on content of the design protocol. Regarding the recommendations of this research, which are based on the study findings, managers institutionalize environmental management responsibilities in the performance evaluation and management system so that employees spontaneously demonstrate professional behavior through increasing green management and healthcare performance in the orientation program for the newly appointed and presented managers and healthcare workforce. Also, develop a green team in the study hospitals to apply the design green hospital protocol. In addition to nursing, medical, and other curricula should be restructured to introduce environmental health, climate change, and the health sector's role in climate change and greening hospitals. Finally, identify ways that sustainability practices as greening hospitals to be incorporated into accreditation standards. Finally, I want to say, around 19 years, long time ago stated that environmental health is regarded as a key element in the moving toward the green economy. So, the summary of my presentation, I gave you an introduction about my research, and then I stated the aim of the study, research hypothesis, methodology of this research, results, conclusion, recommendations, and summary. Thank you very much for your attentive listening and for giving me this chance to be with you today. I'm here waiting for more questions.
Like to propose the lunch break for 20 minutes after we continue the meeting. Please leave the meeting room. Welcome back again. Now I call upon uh, Sandra from Kerala University, USA to deliver her talk on care-based patient scenario, learning active on medication administration shift. Doctor, can you share your screen?
Hey everyone, I'm grateful to have this opportunity to share my research. For this for today's presentation, I will be talking about an engaging class activity that I created when I was teaching an associate degree for nursing students. So I created a case-based patient scenario learning activity on medication administration. The issue of medical errors continue to rise. While I am not a witness to medical errors while teaching nursing students, I am aware that medical errors happen once nursing students graduate. So my aim was to create an activity to increase clinical judgment and decrease medical errors. Research shows only 23% of novice nurses display the competencies needed for the position. An estimated 75% of novice nurses make a preventable medication error. Poor decision-making could cause nursing errors. In the United States alone, an alarming 400,000 medical errors are made annually, with medication errors being the most common. Medication errors result in 7,000 deaths per year. Safety measures have been implemented to decrease medication errors from nurses. However, medication administration remains the most common type of medication error there is. So the problem is not completing the 6 medication rights when nurses are giving medication. The 6 rights are the right patient, the right medication, the right dose, the right time, the right route, and the right reason. Case-based scenarios, also called CBS, showcase a patient scenario. They're an effective, innovative learning activity that helps the learners focus on and highlight issues that may arise when they're giving medication to patients. This goes on the cognitive learning domain. It enhances their critical thinking skills. It enhances their clinical reasoning. It enhances their clinical judgment. Case-based scenarios also are underpinned in andragogy. So when I presented this in course, I had 2 slides. The first PowerPoint slide, I showed a brief patient scenario, the allergies, the home medications, a diagnosis, lab values, vital signs, and then the order. The second PowerPoint slide, I had the same exact scenario, which I will show you. And I highlighted everything in red that was a red flag. Then I gave a rationale. So in order to prepare the learners, you want them to create a sign. I usually have them use a piece of paper and write the words give on one side and hold on the other. You need to allow the learners to use drug books, textbooks, their lab values, anything that they would use in clinicals or as a nurse before they give medication, so they can look it up and know what the med is. You present the scenario and the learners have 5 minutes to read it, to assess it, and to decide, are they going to give the medication or are they going to hold it? After the 5 minutes are up, the learners can decide if they want to volunteer their reasoning behind it, giving the medication or holding the medication. This enhances their clinical reasoning. So here is the scenario, one of them that are presented. Each time when you present something in class, if you're going over congestive heart failure, then your case-based scenario should be over CHF. So we have somebody here who has exacerbation of CHF, complained of shortness of breath and swelling in the lower extremities, and pitting edema was noted. The patient states that they take all of their medication except for their water pill. The comorbidities are hypertension, CHF, MI, breast cancer, and left mastectomy. Their home medications are as follows. The vital signs are all within pretty much normal limits. And then I did give a basic CMP where these are things that the patient or the nurses should be looking at to decide if they're going to give the order aldactone 50 milligrams by mouth twice daily. So this is set up on a PowerPoint in class, and I started a timer and let the nursing students decide if they're going to give this medication based on the scenario, the history, the meds, the vital signs, and the lab values, or if they're going to hold the medication, not give it. After the 5 minutes are up, what should be presented is the information to help them decide whether they're correct in giving or holding the medication. I highlight them in red so they can take note, they can highlight it themselves, they can write it down on a piece of paper and say, oh yeah, we are giving it for the right reason. They do have CHF. You know, the symptoms indicate CHF, and there really isn't anything else that should be red flagged here except for this potassium level. Now, the potassium level was very high at 5.9. And aldactone is a potassium-sparing diuretic. So under here, I have that they would hold it, and I give the reason why. The normal lab value of potassium, why the potassium is high, and why this medication would make it even higher, which would be why we would hold the medication. This can be done for any kind of comorbidity, any kind of medication. And as we went through things that I was taught, I put on here as case studies and had them practice assessing and figuring out if they were going to give or hold the medication. So how do you implement CBS for learners? Well, you utilize your learning format. So if you're using PowerPoint, whatever you might use, if you're on site, or if you're using an online learning format, you definitely even use breakout rooms. You can use, and so you can have them show on their camera and then make little signs of give or hold, or you can have them raise their hand in online learning format. You present the case right after you give a lecture on this specific disease and the information. So this is a safe area and a safe place. Nobody's going to get injured. And once it continues, you start very easy, build their confidence. And each case study really needs to be appropriate for the level of the nursing that they're in. So if they're in fundamentals, the first nursing course of their nursing program, you want to start very easy and only things that you are talking about. As they progress throughout the program, difficulty should progress. You could put in everything be normal, but the allergies, you could, do their oxygen level is off. You can have different things. You could even throw, I have done this where everything was completely fine, except the order was wrong. So the dosage was wrong. And because they have those dosage books in their can, they're able to look the medication up and say, oh, there's an error here. I would hope, and this is the reason why. So the research that I did, I conducted on a medical surgical nursing course for the first year nursing students in the associate program. The program was on site. We did not have any hybrid, but I did, not only did I have this that I just showed on a PowerPoint, but I printed it out so they were able to highlight it using pens or underline it. I did use the CBS at the last 20 minutes of class. So instead of giving them time to sit there and reflect or do other activities, they loved this. So 20 minutes in class, whatever I presented for the day was presented on the case study. The results I found. So it definitely increased the learner engagement in the course-room. Learners were taking notes, they were taking pictures, they're asking questions. 100% of the learners participated in this activity. 75% of the learners participated in giving rationales. So after that 5 minutes, I gave them the opportunity. I did not call on anybody if they wanted to give rationales. And in the beginning, there wasn't many students giving the rationales, but as we continued, they got very excited. Their confidence grew. And they began giving more and more information, raising their hand. By the time we were done, they said, oh, can you do this again? They wanted every single class that I taught on every single comorbidity that was taught in class. They felt more prepared for upcoming quizzes and exams in the pharmacology course. They also said they felt more confident going into their clinical rotations and giving medication. They felt because of what we're learning in class, they were seeing it in their clinical rotation. So that increased their confidence level. When I had talked to their clinical instructors, they said, this was amazing. The results were amazing. The students were recognizing medication from the CBS that we were doing in the course room. They were more engaged and more confident looking up those medication and presenting it to their course instructor. With the case studies that I was doing, I did not, because it was kind of a whim, I wasn't able to see and compare it to when I didn't do the CBS versus when I did. We're in the process of looking at those results now to see if the exams and the quiz scores are even higher. So that's basically what I did. And this can be done for any kind of medical degree. It could be done for MAs, nurses, different LPNs and RNs, and your traditional bachelor degree programs. You can implement these. You can also implement the CBS in multiple disciplines and have them learn how different things. So you can look at different medication that might be causing issues with the patients. You could really tailor it to what the learners are learning in class. And that would be it. So
Thank you for your presentation. If anybody have any questions, please ask them. If anybody have questions, please ask her. Thank you for your presentation. We did not get any questions. Now I call upon.
thank you.
Thank you. Now I call upon Sachima Namdi Ajkivi University, Accra, Nigeria, to deliver his talk on evaluation of anthropometric and metrical parameter in symptomatic HIV male subject not enrolled in antiretroviral therapy, attending Nambia Atri University Teaching Hospital, Nigeria, cross-sectional study. Sachima, please share your screen. Can you hear me? Sachima. Hello, Mr. Sachima. Can you hear me?
Yes. Sorry, I can hear you. Can you hear me now?
Please share your screen.
All right. Okay. Sorry. I'm trying to. I don't know why I'm struggling to do that now.
No problem. Please share.
Sorry, can you share my slide? I think, is it possible for you to share that? I'm struggling with that. I don't know why.
Sorry, we don't have your presentation.
Sorry? Okay.
Please start your presentation.
All right. Thank you very much. Good day, everyone. My name is Sochima John Mark Oviekwe, and I'm a medical student at Nnamdi Azikiwe University Teaching Hospital, Anambra State, located in the southeastern part of Nigeria. So I'll be presenting our research work on the title Evaluation of Anthropometric and Hematological Parameters in Symptomatic HIV Male Subjects not enrolled in antiretroviral therapy attending our teaching hospital. So in this study, we evaluated the effect of malaria as a co-infection to HIV on the anthropometric and hematological parameters of symptomatic HIV male subjects and seronegatives recruited at the our HIV testing center. So HIV is a global condition that has really affected a large population of the world and has impacted both economically, socially, and the physical well-being of those infected with it. So HIV progresses, if not treated, can progress to acquired immune deficiency syndrome. And Nigeria is one of the African countries with higher number of HIV cases. So malaria is also a treatable disease that has affected Africa to a large extent. And studies have shown that malaria as a co-infection can affect the immunity of HIV subjects. And so our study aimed at evaluating the effect of this of malaria parasite on the hematological and anthropometric parameters of subjects enrolled, not enrolled in antiretroviral therapy. So the study recruited 200 adult male participants that are aged between 18 to 65, and 50 of them were symptomatic HIV subjects in stage 2, and they were not enrolled in ARTS, and they also had malaria parasite. Another 50 were symptomatic HIV subjects in stage 2 also, not enrolled in ARTS and without malaria parasite. We also recruited 50 seronegative control subjects with malaria parasitemia and 50 seronegative control groups also without malaria parasitemia. So the anthropometric parameters we evaluated were the blood pressure, systolic and diastolic blood pressure. We equally evaluated the body mass index using a standiometer. Why for the blood pressure? We did that using a mercurial sphygmomanometer and a stethoscope. Then for the hematological parameters, we evaluated the CD4 cells, we evaluated the absolute neutrophil count, we evaluated the erythrocytes sedimentation rate, we equally evaluated the PCV, that's the packed cell volume of the participants. So we used enzyme-linked immunosorbent assay, that's ELISA technique, to analyze or to evaluate the presence of antibodies on the screened blood samples collected from our participants. Then for the CD4 cell count, we determined that using the flow cytometric technique and the estimation of the erythrocyte sedimentation rate was done using the Westergren graduated tube method. Also, for the determination of the white blood cell counts, we did that using a tox solution, which consisted of 1% ammonium oxalates and 2 ml of glacial acetic acid, 100 ml of distilled water, and 2 drops of aqueous violet. And after which we made use of the Newbow chamber through capillary action to the white blood cells. Then for the absolute neutrophil count, we multiply the total number of the white blood cells by the percentage of the neutrophils and then divided by 100. While for the Plasmodium falciparum parasites, we detected this using a thick and thin films, which we are stained with G-MESA 1 in 10 for 10 minutes. And they were both preserved with methanol and viewed under microscope with an oil immersion times 100 objective. We got ethical approval from the institution, and our study, like I said, included participants not enrolled on ART and with and without malaria parasite. So from our result, we observed a statistical significance between the blood pressure of, we observed a statistical significance between the blood pressure of HIV, that's between the systolic blood pressure of participants, seropositive participants with malaria and seronegative participants without malaria. And our findings also yielded a non-statistical difference in the systolic blood pressure studied among all the participants. While for the BMI, that's the body mass index, we observed a statistical difference between participants, seropositive subjects enrolled in ARTS as well as with malaria and those without malaria. We also had a statistical difference between seropositive subjects not enrolled in ARTS without malaria and also seronegative subjects without malaria. Then for the hematological parameters, we observed statistical difference. We observed statistical difference between seropositive subjects with malaria and seronegative subjects with malaria. Statistical difference also existed between seropositive subjects with malaria and seronegative subjects with malaria, as well as seropositive subjects without malaria and seronegative subjects with malaria. Then the discussion of the findings, we observed a significant elevation of the SVP and DBP among the HIV subjects with malaria when compared to HIV subjects without malaria parasite. So these findings equally aligned with other findings that observed malaria parasite as a factor of elevation of blood pressure. So this study suggests that SDL blood pressure could be elevated in malaria infection, with a significant elevation observed in HIV subjects with malaria parasite and seronegative participants with malaria parasite when compared with the blood pressure in HIV subjects without malaria parasite and seronegative participants without malaria parasite. BMI was significantly higher among seronegative subjects without malaria parasite than in HIV subjects without malaria, which correlates with some similar studies. And these findings could be as a result of the wasting that occur in HIV. And because our subjects were not enrolled in ARTS, there was no trend of regaining weight offered by the ARTS drugs. So although positivity to malaria could lead to reduced CD4, as shown by other studies, this study showed no significant difference between two HIV subjects with and without malaria, which is in contrary with some other findings. Then for the PCV level, we observed that the PCV level was slightly higher in HIV subjects with malaria parasite than in HIV subjects So we observed that PCV was slightly higher in HIV subjects without malaria parasite than in HIV subjects with malaria parasite, although there was no significant difference between them. Then
Hello, Sachma. Your voice is not clear. Your voice is not audible. Can you hear me? Hello.
sorry, can you hear me now? Hello, can someone hear me? Can you hear me now?
Please, yes, please start your presentation.
Okay, sorry. I said, in as much as the malaria could induce anemia, as proven by some other studies, the studied seronegative subjects were observed not anemic, like the seropositive subjects were, and therefore the observed anemia is more associated with HIV than effect of malaria-induced anemia, and could be associated with the iron deficiency anemia common among people living with HIV. So in this study also, we observed a significant elevation in the erythrocyte sedimentation rate in HIV subjects than in seronegative control subjects. So the finding is also in line with some other findings where ESR was significantly higher in both symptomatic and asymptomatic HIV subjects than in the controls. So significant elevation in ESR among HIV subjects infected with malaria parasite compared as in HIV subjects infected without malaria parasite was observed, which may be associated with the immune suppression of the virus in addition to the malaria infection. So the white blood cell counts was significantly higher in HIV subjects without malaria parasite than in similar subjects without malaria parasite. However, when we compare the white blood cell counts between the HIV subjects not infected with malaria parasite and the seronegative control subjects infected with malaria, we observed an insignificant, slightly higher WBC count among the control subjects. So in conclusion, the study suggests that HIV positivity has little or no contribution in the elevation of absolute neutrophil, and that not being on ARTS can lower the PCV level. It also suggests that malaria parastemia has little or no contribution in the lowering of the CD4 cells compared to the effect of the HIV infection.
Thank you for your presentation. Now I call upon Mr. Odom Namdi HPV University Akka India to deliver his talk on medical studies and understanding perception and attitudes towards medical procedure. Hello, Odom. Modem, can you hear me?
Yes, I can hear you.
Yeah, please start your presentation.
Okay, so I'm actually in the last phase of the conclusion. So where we concluded that HIV and malaria co-infection are capable of lowering the hemoglobin level and elevating the blood erythrocyte sedimentation rate, the white blood cell counts, and the absolute neutrophil in HIV symptomatic subjects not enrolled on ART. So here are also my my references and my acknowledgement. Thank you for your audience.
Thank you for your presentation. If anybody have a question, please ask. Thank you again for your presentation. We didn't get any question. We will talk about the next presentation.
Okay, thank you very much. Thank you once again for your audience.
Now I call upon Robinson Nandi, HKV University Akka Nambiar to deliver his talk on medical students understanding prescription attitudes towards the as medical procedure. You hear me, Robinson?
Yes, I am here.
Please share your.
Please, I'm getting
Hello, Robinson. Can you hear me? Hello, Robinson. Are you there?
Okay, so good afternoon, good day. I'm supposed to be speaking on the knowledge of amputation as a medical procedure, attitude, perception, and perception of medical students at a Nigerian tertiary university
Yes.
towards amputees.
Robinson,
I'm trying to share
can
my
you please
screen.
share your screen?
Sorry about the glitch. I'm trying to share my screen.
Is there any problem to share? Share the screen.
A little problem. But I'm fixing it now. Can we see the screen?
Yes, now you can. Presentation.
Okay. Yes. So sorry about the glitch once again. Knowledge of amputation as a medical procedure, attitudes and perception of medical students at a Nigerian tertiary university towards amputees. Now, this is just a study that was conducted on amputation across a clinical health students to understand whether they have a good perception of what amputation is all about. And amputation is a loss of an extremity resulting from prolonged constriction, medical diseases or surgery, and often necessitated in advanced disease conditions, which has profound impact on individual lives. Lower limb amputation serves as an indicator of prevalence of diabetes mellitus and other associated pathologies, as well as accessibility and quality of healthcare services. A reduced amputation rate indicates a decreased diabetic incidence and signifies accessible and quality healthcare, whereas an increased amputation rate suggests an increased diabetic incidence and limited access to quality healthcare. Clinical health science students, including those who often encounter amputated patients during their clinical posting, are ones who are going to serve who served as our samples or our participants in this study. Their knowledge, perception, and attitude towards amputees plays significant roles in shaping biological, psychological, social, and physical well-being of amputees. The research methodology. This study was conducted at the College of Health Science, and 613 conveniently selected students in their clinical phase who were selected because they met the inclusion criteria. A semi-structured questionnaire adapted from similar studies was used to collect data. An ethical approval was sought and obtained from Nnamdi Azikiwe University Teaching Hospital. The confidentiality of the participants was maintained, and the questionnaires were administered by trained research assistants. The collected data were analyzed using statistical package for social sciences, version 20, and descriptive statistics and appropriate statistical tools were utilized to interpret the data and draw meaningful conclusions from the findings. So if you look at the chart, you'll find that this distribution showed that the participants are from 3 different religions. The results of this study showed that the 613 male and female participants were included in the study. A majority of students, 85%, were aware of lower limb amputation as a treatment method. Almost all students, 96.6%, had encountered someone with lower limb amputation, mostly during clinical postings. And most students, 71.5%, expressed willingness to encourage lower limb amputation when indicated. They generally perceive lower limb amputation as individual with potential, like other human beings, and expressed empathy and sympathy towards them. The students acknowledged the need for physical support and assistance for amputees, and were willing to help them improve their quality of life. A significant proportion of the students admitted treating lower limb amputees differently in the clinic, and some reported treating them humbly or politely, or avoiding contact or caring for amputees more than non-amputees. 19.9% actually opted for caring for amputees more than non-amputees. So overall, the attitude towards amputation were said or will be said to be relatively poor. So social demographic factors such as age, course of study, level of study, ethnicity, and religion were found to be associated with knowledge and perception of amputation. Age, particularly respondents under 26 years old, was linked to better knowledge and perception. I mean, these persons who are under 26 tend to have lesser knowledge. People who are below 26 years old, they had lesser knowledge of amputation, and just few of them have actually met a patient that was amputated. But people who are more than 26 years old had a good knowledge of amputation and have actually met or had relatives or friends who have had and has undergone amputation. So the course of study also played a role, with medical rehabilitation students demonstrating the highest proportion of good perception, because medical rehabilitation students or physical therapists, they tend to be people who are engaging or have treated or had personal encounter with amputees and managed them to return to work effectively. Attitude towards amputees were influenced by factors such as gender, age, department, level of study, ethnicity, and religion, with female respondents and those older than 26-year-old exhibiting better attitudes. Furthermore, this study found a positive correlation between respondents' knowledge and their perception of amputation, suggesting that higher knowledge levels were associated with more positive perception. These findings emphasize the influence of social demographic factors on perceptions and attitude towards amputation and amputees. It underscores the need to consider these factors when developing educational and awareness campaign to improve understanding and attitude towards amputation and amputees. Conclusively, the study revealed that medical students generally perceived amputation as a beneficial treatment option, and particularly the pain reduction and infection prevention. Because yes, these are the students that tend to, especially students in medical rehabilitation, because we actually got students in different departments, including environmental health sciences, radiography, radiology, medical laboratory sciences. I would like you to look to my chart where I have a distribution of course of study. You see that these persons were actually selected from different departments in the College of Health Sciences in Nnamdi Azikiwe University. So, but then the students in medical rehabilitation tend to have higher perception of amputation as a treatment procedure. So the findings highlighted the influence of social demographic factors on students' perception and attitude towards amputation and amputees, indicated a moderate level of knowledge, a positive perception towards amputation, and a mixed attitude towards amputation among the study participants, which emphasized the need for interventions and educational programs to foster better understanding and inclusion. So references from Physiopedia, references from the Bureau of Health Information, and the journal Amputation as a Marker of the Quality of Foot Care in Diabetes. So with this, I'll come to a conclusive end of this presentation. Thank you very much.
Thank you for your presentation. If anyone has a question, please ask me. We didn't get any questions. Thank you for your presentation once again. Thank you for your precious time for our session and the model of this great session. We put all our routine experience for our virtual session. We are successful complete today's session and we will send all set by email. Thank you. Have a great day.
Thank you.
Thank you.